welcome to the deep dive. You sent us a really interesting collection of sources this time.
Yeah, quite a mix.
Everything from how medical braces and artificial limbs are legally defined, all the way down to some really detailed clinical guidelines for, well, a super common type of pain,
Yes.
heel pain. So today, we're going to quickly touch on that landscape of orthotics, prosthetics, pedorthics, just to kind of get our bearings, you know.
Right, set the stage.
And then we're going to spend most of our time really digging into those guidelines on what physical therapy interventions are actually proven to help with heel pain, specifically plantar fasciitis.
They're a fantastic set of documents, actually, because you
Ah.
get that broader picture of some related health professions, and then it really zeroes in on the practical evidence-based strategies for a condition that, frankly, affects a huge number of people.
Exactly. So our mission for this deep dive is to pull out the absolutely essential nuggets of knowledge. We want you to walk away feeling well-informed about what this specific heel pain is, who tends to deal with it, and maybe most importantly, what treatments the research actually supports. Let's jump in.
Okay, so before we get right into the heel pain itself, let's quickly set the scene using that first source. It lays out some definitions for devices that help support or replace parts of the body.
Right. It talks about things like orthosis. And this isn't just any basic support you grab off the shelf at the drugstore, is it?
No, exactly. That's a key distinction. And orthosis is basically a brace or support or a splint that's either custom made just for you or it's custom fitted to you.
Okay.
It's designed to support or correct or maybe even prevent issues with muscles or bones. And importantly, the sources note that for therapeutic use, these typically need an order from a licensed physician or a foot doctor, a podiatric physician.
Ah, so it's prescribed.
Pretty much. Think of it as a prescribed device, not just like a general support.
Gotcha. Then you've got prosthesis, which is probably more familiar to most people. That's an artificial device that replaces a missing external body part, like a limb, a hand, or a foot. Again, usually ordered by a physician.
Okay. And then pedorthic devices.
Yeah.
This term feels a bit closer to our main topic today since it covers stuff for the foot and ankle.
It does, yeah. Things like therapeutic shoes or modifications made to shoes for therapy and foot orthoses.
Which are like inserts.
Exactly, like shoe inserts, but specifically ones used for therapeutic purposes at or below the ankle.
Right.
And similar to orthoses, these therapeutic pedorthic devices generally need a physician's order too. They specifically exclude things that aren't really for therapy or, prefabricated things not specifically intended for that therapeutic use.
So thinking about the professionals involved, orthotists, prosthetists, pedorthists, these are healthcare pros with specialized training. They deal with these custom or custom-fitted devices under a doctor's direction. And while our main focus today is plantar fasciitis, which is often managed by physical therapists,
It's useful to understand this related world, because devices like orthoses can potentially play a role in foot pain management, though, as we'll see, the way they're used really matters.
absolutely, it's all connected.
Okay, let's get to the main event then. We're unpacking those clinical practice guidelines on plantar fasciitis. So what exactly is plantar fasciitis and how does someone typically, figure out they might have it?
Well, plantar fasciitis is basically the #1 reason someone has pain on the bottom of their heel, what we call plantar heel pain.
Okay.
The guidelines describe it pretty specifically as pain on the inner part of the bottom of the heel, right? Where that tough band of tissue, the plantar fascia, attaches to your heel bone.
Right there at the attachment point?
Exactly. And here's where it gets really interesting and quite specific for diagnosis. The pain is usually worst with your very first steps in the morning.
Ah, that classic symptom.
Yeah, or after you've been sitting for a while and then you stand up. That first step's pain is a huge clue. It also often flares up after you've been on your feet for a long time.
Yeah.
Prolonged weight bearing.
That morning pain pattern. You hear about that a lot. Who is most susceptible to getting this?
It's actually very common. Makes up something like 15% of all foot problems. It most often affects people between, say, 40 and 60 years old. And while it doesn't strongly favor men or women overall, it is reported more frequently in runners and also in people whose jobs involve a lot of standing, especially on hard surfaces that don't absorb much shock.
Makes sense.
And it typically doesn't just appear overnight. It usually starts gradually, often after maybe a change in activity or just how much weight you're putting on your feet.
And the guidelines even mention it's classified using international medical codes, right?
Right.
Which really shows how, well, widely recognized it is as a specific condition. And they link it to how it affects your body's function, causing pain in activities like walking, standing, running. It really highlights how much it can disrupt daily life.
Absolutely. And the guidelines list specific risk factors that a physical therapist will look for and assess.
Like what?
Things like having limited flexibility in your ankle, specifically not being able to bend your foot upwards very far.
Dorsiflexion.
That's the one, limited dorsiflexion. Also, having a high body mass index, or BMI if you're not an athlete, running, as we mentioned, and work that demands heavy weight bearing, especially in conditions with poor shock absorption, like hard floors.
Okay. So how does a PT actually diagnose it? The guidelines give some direction there.
They do, yeah. A pretty clear roadmap. It starts with listening to your story, hearing about that classic pain pattern, especially the morning pain or pain after rest.
And then comes the physical exam, I assume. What are they looking for specifically?
Well, they're looking for tenderness when they press on that area where the plantar fascia connects to the heel bone, that proximal insertion.
So poking around that specific spot.
And a specific test called the windlass test can also be indicative.
Windlass test.
Yeah, think of like tightening a winch on a boat. When they gently extend your big toe upwards, it puts tension on the plantar fascia. If doing that recreates your specific pain, it suggests the fascia is involved.
Interesting.
And crucially, it's also about ruling out other potential culprits for heel pain.
Like what else could it be?
Things like tarsal tunnel syndrome, which is kind of like a pinched nerve in the ankle region, or even a stress fracture, a tiny crack in the heel bone itself.
Right.
So the exam should involve tests that rule these things out. Tests for those conditions should be negative, and the pain shouldn't be recreated just by pressing directly on the bone itself, or say, the middle part of the fascia away from the heel.
What about imaging, like x-rays or MRIs? Do you always need those to confirm it?
That's a great question. According to these guidelines, imaging usually isn't the first step. Not if your clinical exam strongly points towards plantar fasciitis. It's typically considered later, maybe if more conservative treatments like the physical therapy we're discussing aren't providing enough relief.
So if things aren't getting better.
Exactly.
Yeah.
And if imaging is used, standard weight-bearing x-rays are often done first. If those come back negative, but the PT or doctor is still concerned about the fascia or maybe some nerve irritation, then an MRI without contrast or a diagnostic ultrasound is usually the next appropriate step.
You mentioned ultrasound. Can that show anything specific?
It can. The guidelines mention that specific findings on an ultrasound, like the fascia appearing thicker than, say, 4 millimeters, and maybe having a darker look on the image, which can suggest inflammation or tissue changes, those can be seen in plantar fasciitis. But, and this is a really important caution, they add some of those imaging findings can actually be present even in people who don't have any symptoms at all.
Oh, interesting.
Yeah. So imaging is really just one piece of the puzzle. It's not usually the primary way to diagnose it initially. It supports the clinical picture.
Okay, this is where we really get to the heart of it. What actually works according to the research? The clinical practice guidelines dive deep here, right? Grading treatments based on the strength of evidence.
They do. They grade them from A, meaning strong evidence, down through B, C, D, and even E for expert opinion.
So what gets the top grade? What are the A treatments with strong backing?
Okay, so several interventions get that highest level A recommendation.
Right.
First up, manual therapy. This is the hands-on work that physical therapists do. The strong evidence suggests they should be using techniques like joint mobilization.
Gently moving the joint.
Exactly. Gently moving joints in the foot, the ankle, maybe even related areas like the spine if needed. And various soft tissue mobilization approaches to address tightness and restrictions in the muscles and tissues of the lower leg and foot.
Okay.
Studies show these can help decrease pain, improve how well you can move, and just generally improve function. The guidelines mention specific techniques like dry cupping, specific myofascial trigger point therapy, and also IASTM. Yeah, instrument-assisted soft tissue mobilization. Basically using specialized tools to help release tight spots in the fascia or muscles.
Got it. So it's clear that hands-on treatment from a therapist is definitely well supported by the research.
Absolutely. Another top-tier level A recommendation is stretching.
Makes sense. Which stretches specifically?
Specifically stretching both the plantar fascia itself
Okay.
and also the muscles in the calf. That's the gastrocnemius and the soleus muscles.
The big calf muscles.
Right. Research strongly supports this kind of stretching for both short-term and long-term pain reduction, and also for improving function and reducing disability.
So it helps now and later.
Seems so. There's even some evidence suggesting that stretching the plantar fascia directly might be maybe even more effective in some ways than just stretching the calf muscles alone. The only side effect reported is occasionally some mild increased pain while you're actually doing the stretch.
Okay, that seems manageable. What about taping the foot? I've seen athletes with tape on their feet. Does that help here?
Yes. Taping also gets a strong level A recommendation. The guidelines say physical therapists should use foot taping techniques. Could be rigid tape, could be elastic tape.
Kinesio tape, maybe?
Yeah, things like that. But here's the key. It's recommended in combination with other physical therapy treatments.
Ah, not just on its own.
Right. Primarily for short-term benefits, usually looking at the first 1 to 6 weeks, helping with pain and function during that initial phase. It's seen as an effective tool for getting some quick relief alongside other therapies. Mild skin irritation is a possibility, but generally pretty minor.
Okay. And I've definitely heard about using night splints for this condition. Are those recommended too?
Yes, night splints also receive that strong level A recommendation.
Ugh.
These are recommended as a program used for about 1 to 3 months, and they seem particularly helpful for people who have really significant pain with those first steps in the morning.
Because it keeps the foot stretched overnight?
Exactly. These splints gently keep your ankle and foot in a more neutral, slightly stretched position overnight. This prevents the plantar fascia from tightening up in that shortened position while you sleep, which is thought to be a big reason for that awful morning pain.
Okay, so summing up the strong A list. Manual therapy, stretching both the fascia and the calf, taping, but used with other PT, mainly short-term, and night splints, especially good for that morning pain. Got it.
You got it.
What about treatments with maybe moderate evidence, those level B recommendations?
Okay, moving to level B. This group includes foot orthoses, those inserts we mentioned earlier.
Right.
But there's a really important nuance here. The guidelines state pretty clearly that clinicians should not use orthoses whether they're prefabricated, like off-the-shelf, or custom-made as the only treatment for pain relief in the short term.
So just popping in an insert isn't the answer initially.
The evidence suggests not, at least not on its own for those first few weeks. The research shows they don't really do much when used in isolation early on. But the recommendation then shifts slightly. It goes to a level C, which is weak evidence, suggesting that clinicians may use orthoses, either custom or prefabricated, when they are combined with other treatments.
So as part of a package deal.
Exactly. To help reduce pain and improve function. Studies do indicate a benefit when orthoses are part of a broader plan, and some lower quality evidence hints at potential benefits lasting maybe 6 months to a year, with some findings even favoring custom orthos over other treatments in the long run.
So less of a quick fix, more about potential support within a comprehensive plan, maybe longer term?
That seems to be the takeaway, yeah. It's about integration, not isolation.
Okay, what else is in that moderate level B category?
Another one is low-level laser therapy, often just called LLLT.
Light there.
Yeah, it's a type of light therapy. The guidelines say it should be considered as part of a rehabilitation program for both recent acute cases and longer-lasting chronic plantar fasciitis, specifically to help decrease pain in the short term. We're talking maybe 1 to 3 months.
So mainly for pain relief early on.
Primarily, yes. While it shows promise for pain relief, the evidence seems less consistent for helping with overall function or, how it stacks up directly against other treatments like ESWT, that's extracorporeal shockwave therapy, often used outside of PT.
Yeah.
Using specific laser settings like those recommended by expert groups like the World Association for Laser Therapy seems important for getting better results.
Yeah.
And good news. No harms were reported for LLLT in the studies they reviewed.
That's good. Anything else at level B?
Yes, one more. Dry needling. This has moderate level B evidence.
Needles, huh? Like acupuncture?
It's different from traditional acupuncture, though it uses similar thin needles. Here, it involves inserting the needle specifically into muscle knots or trigger points.
Oh, yeah?
The guidelines recommend clinicians should consider using this technique, particularly targeting trigger points in the calf muscles, gastrocnemius and soleus, and also muscles within the foot itself.
And does it help?
The evidence supports its use for both short-term and long-term pain relief, and also for improving function and disability, especially in cases where the pain has lasted longer than about a month, so more chronic cases.
Right.
It's often used alongside other treatments like stretching and manual therapy, although one study they mentioned suggested it could potentially be effective even on its own. Minor soreness or maybe a tiny bit of bleeding at the needle site are possible, but generally brief side effects.
Okay, so we've got the strong recommendations, A, and then a few with moderate evidence, B, like LLLT and dry needling, plus that key distinction about how orthos should be used part of a plan, not alone short term.
Right.
Are there any treatments that the guidelines actively recommend against using? Things to avoid?
Yes, definitely. There's a strong level A recommendation against using therapeutic ultrasound specifically as a way to boost the effects of stretching.
So not ultrasound in general, but specifically trying to use it with stretching.
Exactly that context. Studies directly compared using ultrasound plus stretching versus just doing the stretching alone or with a sham ultrasound, or compared ultrasound to other treatments like ESWT. They consistently found no significant added benefit from the ultrasound for either pain or function in this situation.
That's a really key takeaway because I feel like ultrasound was used a lot historically for this.
It absolutely was.
Yeah.
But the current strong evidence says it doesn't add value when combined with stretching for plantar fasciitis.
Okay. What about other electrical things?
Yeah, electrotherapeutic modalities in general, things that use electrical currents like 10NS or interferential current, they receive a level D recommendation. That means the evidence is conflicting or limited.
So not a strong yes or no.
Right. For promoting intermediate and long-term improvements, the guidelines actually recommend clinicians should prioritize those level A things we talked about: manual therapy, stretching, and foot orthoses, used appropriately.
Got it.
However, based on some lower quality evidence, they say clinicians may consider using specific types like iontophoresis.
That's using current to deliver medication through the skin, right?
Yes, or pre-modulated interferential current. But these are suggested more as a secondary option, maybe if other things aren't working, because the research on them shows smaller, less reliable effects.
Okay, so not the first line of defense.
Generally, not for longer-term goals, no.
What about other types of interventions? Maybe things with weaker evidence, level C?
Yep, there are a few in the level C, or weak evidence category. One is therapeutic exercise and neuromuscular re-education.
So exercises.
Yes, strengthening exercises specifically. The guidelines state that clinicians should prescribe exercises that include resistance training for the muscles in the foot and ankle.
Strengthening the foot itself.
And the ankle muscles supporting it. Now, the evidence isn't strong enough yet to pick out, say, exactly which exercises are best or to perfectly isolate the effects, but the studies they included in the review do show that strengthening exercises can be effective. Interestingly, supervised rehab programs that included strengthening sometimes showed better results than just telling people to do exercises at home. And one study even suggested that strengthening might actually be better than stretching alone for improving function and pain in the longer term.
Huh. That's interesting. Strengthening over stretching long term.
Potentially, based on that one study. Needs more research, but it suggests strengthening is definitely worth including.
Okay. What else is C-level?
Photophoresis, with a specific anti-inflammatory gel like ketoprofen, is also mentioned at level C. It's listed as something that may be used to reduce pain. Photophoresis is kind of like ultrasound, but the goal is to use the sound waves to help a topical medication penetrate the skin, though the updated guidelines didn't find any new studies on this particular topic. For thermal agents, like heat, also level C, weak evidence. The guidelines mention, based on one specific study, that clinicians may recommend applying local heat for about 4 hours to trigger points in the calf muscles using a specialized wrap or device. In that particular study, it showed some immediate pain reduction and improved pressure tolerance. So, very specific context there.
Right, based on one study.
And finally, there's education and counseling for weight loss. This gets a level E, which is basically expert opinion.
So, not strong research studies, but experts think it's relevant.
Exactly. Given that higher BMI can be a risk factor, the experts who wrote the guidelines felt clinicians may provide education on exercise to improve body composition and maybe refer patients to other professionals, like dietitians, for nutrition advice. It reflects that weight management could play a role, but there weren't direct studies of weight loss interventions specifically for treating plantar fasciitis included in this guideline update.
Okay. It really sounds like there's no single magic bullet here, and that effective physical therapy often involves using several of these approaches together, like a multimodal intervention.
That's exactly right. The guidelines implicitly support this idea. They note that combining things like, say, Manual therapy, exercise, and maybe modalities like LLLT or dry needling seems to yield benefits.
Putting the pieces together.
Precisely. While maybe more research is needed on the best specific combinations for different people, the overall concept of a multifaceted approach really customized to the individual's specific needs based on their evaluation. That seems to be key based on the evidence presented here.
And the guidelines also briefly mention other interventions, stuff often done outside of PT, right? Like shockwave or injections.
They do, yeah. They touch on things like ESWT, extracorporeal shockwave therapy, corticosteroid injections, often just called CSI or steroid shots, and platelet-rich plasma, or PRP injections.
What do they say about those?
They basically summarize that these can be effective. For example, ESWT seems promising for medium-term relief, and maybe PRP for short-term. But they also flagged concerns that came up in the research they reviewed.
Like what?
Things like conflicting evidence specifically for steroid injections, the overall quality of evidence for some interventions being low, potential side effects for steroid injections being underreported in studies.
Side effects like what?
The sources mention things like fat pad atrophy, where the natural cushioning under the heel thins out, or even, in rare cases, rupture of the plantar fascia itself.
Oof, okay.
Yeah. And some evidence also suggested that ESWT might actually be better than steroid injections in the medium term. So these are mentioned as potential options, especially as standard physical therapy isn't giving enough relief. But the guidelines also importantly note the varying evidence levels and potential risks as reported in the sources they reviewed.
Right. It's good to be aware of those other options and their associated evidence. So, stepping back a bit, why does knowing all of this detail, all these grades of evidence, matter to you, our listener? Whether you're actually experiencing heel pain right now or maybe just want to understand what good evidence-based care looks like.
Well, these guidelines are essentially a massive, systematic synthesis of the best available research specifically on physical therapy for plantar fasciitis.
Okay.
So what we've discussed means you can feel pretty confident that when a physical therapist uses hands-on techniques like manual therapy or recommends specific stretches or maybe suggests taping or talks about night splints, they are doing so based on strong scientific evidence. It's not just based on tradition or, what someone anecdotally thinks works.
It gives you the why behind the treatments you might receive or be offered.
Exactly. And it also helps clarify why certain things you might have heard about, like maybe just relying solely on an arch support for quick relief, or using therapeutic ultrasound to boost stretching, why those might not be the primary recommendations based on the current research. Because the evidence either doesn't strongly support them in that way,
Or, in the case of ultrasound, added to stretching, actually recommends against it.
right.
So ultimately, understanding these recommendations empowers you. It helps you ask informed questions and have more productive, collaborative conversations with your physical therapist or other healthcare providers about your treatment plan. It helps ensure the care you're getting is aligned with the most up-to-date evidence.
Wow. That was a truly comprehensive look at plantar fasciitis, all through the lens of these clinical practice guidelines. And we got that quick look at their related fields of orthotics and pedorthics, too. It's pretty amazing, actually, how much rigorous research goes into figuring out the most effective ways to treat something as common, really, as heel pain.
It absolutely is. It really highlights the value of evidence-based practice and also how our understanding of what works best continues to evolve as more and better research emerges over time. So here's maybe a final thought for you to mull over, building on all this. Given that plantar fasciitis often seems to involve this mix of factors, right? Like tightness in the tissues, maybe some weakness in the supporting muscles, or even just the way you're using your foot during activity.
Right, it's often multifactorial.
And considering that so many of these recommended interventions target different aspects, some improve mobility, others build strength, others reduce strain, how important might it be that physical therapists are not just picking one or two things off the list, but rather really customizing the combination and maybe even the sequence of these evidence-based treatments specifically for your individual situation? Could that overall integrated approach tailored to you potentially be even more critical than the effectiveness of any single technique used alone?
That's a really interesting point to consider, the synergy of the approach.
Something to think about. Thanks so much for joining us for this deep dive. We really hope this helps you feel more informed and maybe a little less overwhelmed by all the information out there.